Hello, this is Dr. Vanessa Grubbs from the University of California, San Francisco, with a CJSON podcast about our manuscript entitled Characteristics and Outcomes of In-Hospital Palliative Care Consultation Among Patients with Renal Disease versus Other Serious Illnesses, a retrospective cohort study from the Palliative Care Quality Network. I performed this study in collaboration with colleagues Drs. David O'Riordan and Steve Panalat, also from UCSF. Prior studies have shown that aggressive and invasive care are the norm for dialysis patients at the end of life. On the other hand, palliative care consultation happens much less often for patients with end-stage kidney disease than it does for patients with dementia or cancer. We wondered whether this is because dialysis patients are perceived as having less need for palliative care services. We analyzed data collected by interdisciplinary palliative care teams that are members of the Palliative Care Quality Network, a national palliative care quality improvement collaborative. We compared characteristics and outcomes of hospitalized patients in the United States who had a palliative care consultation for kidney disease to patients with a palliative care consultation for another serious illness, such as cancer, heart disease, pulmonary disease, or neurologic disease. We assumed kidney disease referred to end-stage kidney disease since patients with earlier stages wouldn't be sick enough for their kidney disease to warrant a palliative care consultation. The data for this study included palliative care consultation records of 33,183 patients from 38 hospital palliative care programs in 11 states that received consultation requests between the dates of December 12, 2012 and March 15, 2016. The average age of patients in this cohort was about 72 years, and 1,057, or 3% of patients had kidney disease as the primary condition prompting consultation. Palliative performance scale scores suggested that all patients were nearly completely bedbound, had reduced dietary intake, and required full assistance for self-care. Symptoms were common and severe among patients with kidney disease and among those with other serious illnesses. About 15% had moderate to severe anxiety and about 6% had nausea. However, symptom management was less likely to be the reason for palliative care consultation for patients with kidney disease. Severe pain was present for 25% of patients with kidney disease versus 31% of patients with other serious illnesses, and dyspnea was present for 30% of patients with kidney disease versus 42% of patients with other serious illnesses. However, the symptoms of patients in both groups were equally likely to improve after palliative care consultation, and a higher percentage of patients with kidney disease reported improvement in anxiety. Patients with kidney disease were more likely to have goals of care stated as a reason for palliative care consultation. Among a subset of 6,364 patients with available data, there were no differences in the code status of patients with kidney disease versus other serious illnesses at the first consultation or at discharge. Nearly 2/3 of patients in this subset were full code at initial consultation, but a significant proportion changed code status. Roughly 2/3 were do not resuscitate, do not intubate at discharge. One limitation of our study is that we only examined patients who had a palliative care consultation. As a result, our cohort may have selected for the sickest kidney disease patients, possibly not reflecting the needs of the entire in-hospital kidney disease population. All in all, our study showed that patients with kidney disease for whom a palliative care consultation was obtained had similar palliative care needs, similar improvements in symptoms, and similar clarification of care goals compared with patients with other serious diagnoses. Perhaps routine screening at admission to identify patients who would be appropriate for palliative care consultation would improve end-of-life care for more patients with end-stage kidney disease.
This podcast is copyrighted by the American Society of Nephrology, all rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare provider if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast of the American Society of Nephrology.